All right, now we're going to talk about congenital heart defects. On the second slide here, you'll see some different websites that'll talk about both of those issues. Both of those sites will talk about congenital heart defects. You might want to look those up on your own. Now, some terms you're going to need to know: cardiac output, and I won't go into all these because you've had this before. Preload, afterload, contractility. That gives you some definitions. This just shows you the anatomy of the heart, the different areas. You should be aware of that. Fetal circulation, you should have already went over already. So you know about the foramen ovale, where blood passes the fetal lungs and in the opening between the right and the left atrium, and then the ductus arteriosus, the channel between the pulmonary artery and the aorta. Now, congenital heart defects, incidence in newborns, in full-term babies is about 8%. Preemies is even higher. Gender, it affects more males than females in total number of defects. Now, the etiology is basically unknown. Embryonic structures do not close at birth, or the heart is formed incorrectly. Now, contributing factors: viruses such as rubella, CMV, varicella. Genetics also can play a part. Medications, drugs, and alcohol abuse. So, any type of addictions, those type of things, medications that the mother might be on. Other abnormalities such as Down syndrome. Also, the maternal age of the mother, if she's greater than 40 or has diabetes, also plays a factor. Now, classification is done through increased pulmonary blood flow, left to right shunt, and decreased pulmonary blood flow, that's right to left shunt, and then obstruction of the left ventricular outflow. So pressure in the heart chambers is important for you to review assessment of the child with CMV alterations. So look back in your book. You also need to know the diagnostic tests and the nurse's role in care. So you need to pay close attention to cardiac cath section in your PEDS maternity book. And this just goes to show some of the congenital defects that are problems with the heart structure that are present at birth. This shows you some of the different things that occur. This slide does. Now, defects with increased pulmonary blood flow, where the blood flow from the left to right atrium or left to right shunt. This is usually caused by abnormal opening or connection in the heart or great arteries. It leads to CHF, increased respiratory infections, and endocarditis. Now, shunting of the blood from the right side, defects with decreased pulmonary blood flow will be shunting of the blood from the right side of the heart to the left side of the heart, or right to left shunt. And this is mixed blood in the systemic circulation. This leads to hypoxia, cyanosis, polycythemia with an increased hematocrit, and erythrocytosis. Usually congenital heart uh, defects, the symptoms, you're going to have an increased pulse, increased respirations, retarded growth or slow growth, fatigue, and URI. Now, history, you need to find out the chief complaint. You need to look for any kind of presenting symptoms. When was the onset? When was there? What kind of relieving factors? The severity of the symptoms. You need to include the caregiver in this, getting this history. If it's an adolescent, they should be the primary historian. Um, you need to find out if some of these things are they trying to keep up with their peers? Is that why some of these symptoms are occurring? And then conditions associated with congenital heart defects, you need to review those. Um, if these are newborns, you need to ask about the maternal history. So if it's an infant, you need to know pre and postnatal history and eating patterns. Um, if there's any kind of cyanosis occurring, you need to find out when and what kind of activities cause it. You also need to know a family history. So you need to know anything congenital kind of history that's occurred. Do any of the family members have any kind of congenital defects? Also, the growth and development. Is there any kind of retardation or any slowing of the growth and their development? Also, their exercise tolerance. Is there any restrictions? Do they have problems trying to run or trying to walk or whatever? Do they have any kind of shortness of breath? Any color changes in their skin? Dizziness or palpitations? You need to get a good assessment and history of that. In those assessment, you need to inspect their facial features. Um, you want to make sure that they're growing. You know, you should be able to tell if they're not growing up to speed, or if they have some type of um, congenital defect such as Down syndrome. You need to check their chest, inspect their chest, their skin color, look for any edema, any finger clubbing. On auscultation, you want to look for any kind of murmurs, location, timing, frequency, intensity. You want to note if the systolic is loud, is considered abnormal, and it needs further evaluation. Not all murmurs are pathological, so intensity of your heart will increase with fever, illness, and stress. This is just a little thing that talks about heart murmurs. Uh, Heart murmurs are usually heard with congenital heart defects. Innocent murmurs are usually of no significance, so you need to reassure parents um, that there's no restrictions, no follow-up needed. Now, further assessment, we talk about palpitation. You want to check their liver, see if there's any hepatomegaly. That's a sign of CHF. Their blood pressure, you need to make sure you use the right equipment. You need to do arm and leg measurements and compare the two. Serial measurements, you need to do repeated measurements on visits and note those. Now, diagnostic tests, they could do an echocardiogram, they could do cardiac catheterization, or they could do an MRI. Now, if they do a cardiac cath, the patient has to be NPO 4 to 6 hours before time. You need to assess for any kind of allergies, so latex allergies, any allergies to any dyes, anything like that. Post-op, you're going to evaluate the extremity distal to the cath site. You also want to make note of their kidney function, their I and O. because the dye usually they're going to try to flush that out with fluids. It should cause diuresis. So you want to see a good urinary flow after they've had a cardiac cath. Congestive heart failure. Uh, Incidence is unknown due to a wide range of causes for CHF in infants and children. Um, Acquired heart diseases lead to CHF, so cardiomyopathy, endocarditis, rheumatic fever, myocarditis, all those things. So basically, congestive heart failure is the inability of the CV system to provide adequate cardiac output to meet the metabolic needs of the body. Your incidence, like we talked about, is unknown. Etiology is, you know, CHD are the leading cause for CHF in infants. Acquired heart disease is the most common cause of CHF in older child and adolescents. And this is just a chart that shows the different psychological mechanisms of CHF. Um, physiological symptoms of VHF. Um, and you've went over congestive heart failure before. Now, clinical manifestations you're going to see in newborns and infants, you're going to see tachycardia, gallop rhythm, diminished pulses, diaphoresis, cool extremities, mottled extremities, pallor, edema, failure to thrive or poor weight gain, restlessness, tachycardia, retractions, wheezing, rales or rhonchi, hepatomegaly, and lower urine output. In children and adolescents, you're going to see JVD, wheezing, rhonchi or rales again, dyspnea, orthopnea, and this just goes down to different lists, but you need to be familiar with those and know the difference between the two, between a child and a newborn. Now, with your right side, of course, you're always going to have systemic congestion, and that's going to cause JVD, hepatomegaly, and peripheral edema. Your left side is more on the pulmonary congestion, and you're going to have tachycardia, crackles, and feeding difficulties. This is just a little thing that talks about left-sided heart failure. You know, they're going to have cyanosis, all this different things. So just be aware of the difference between left and right-sided. Here's one with right-sided on it. It talks about the different things. So treatment, you want to reduce volume load. Usually that's done through diuretics. Increased contractibility, and you want to decrease the afterload, and also nutrition will help. So nutrition, we talk about, what do we talk about with CHF? You want to reduce their sodium. You don't want them retaining fluid. You want to eat good protein. Keep them thin, not a lot of weight, as that will add to the congestive heart failure. You want to reduce volume overload, like we talked about with diuretics or fluid restrictions. Now, these patients are going to have to be told about when to take their diuretics. You know, take them in the morning, don't take them at night. Things to watch for if they take too much. You know, if they're on too much, they could get have episodes where they're passing out and different things like that. So we need to make them aware of teaching with diuretics. Now, to increase the contractibility, contractility. We're going to look at digoxin, sympathomimetics, and also phosphodiesterase inhibitors. And you need to be aware of those medications. You should have a list of those medications already. Now, the grease afterload, we're going to look at ACE inhibitors, ARBs, nitroglycerin, and nitroprazide. You're especially going to see nitroprazide used in people that have severe congestion, heart congestion, severe weight gain in the hospital. Usually that's done in the ICU, and they'll put them on a nitroprazide drip, trying to decrease their blood pressure and also decrease their volume of fluid. Nutrition. We want to talk about meeting the increased demand. So you're going to look at the concentration of the formula, 27 to 30 calories per ounce. You also do not want to fatigue the child. So if they've got heart failure, it's going to take a lot of different feedings. They're not going to be able to sit for a long time. Look at the concentration of the formula, make supplementation of breastfeedings, and some of these children might be put on an NG, nasogastric, or tube for feedings. Now, nursing care, major nursing diagnosis for this would be decreased cardiac output, fluid volume excess, imbalanced nutrition. Family teaching, you're going to have to teach them about the feedings that they're going to have to. They're not going to be able to feed them a lot at once, that they're going to get wore out. They have to feed them, that they need rest periods, and basically family support during this time. And this just goes to show you a different slide of a normal heart, what it's supposed to look like. Now we'll talk about defects with increased pulmonary blood flow. That's blood flow from the left to right, or left to right shunt. And it's usually an abnormal opening or connection in the heart or great arteries that leads to CHF, increased respiratory infections, and endocarditis. Now there's different types. There's an atrial septal defect, ventricular septal defect, patent ductus arterius, and then we'll have the arterial ventricle canal defect and the truncus arterius, but we're not going to discuss those. You can just read those in the book. Your atrial septal defect, the incidence is going to occur in 6 to 10% of all congenital heart defects. Girls are going to be more affected than boys, 2 to 1. Pathophysiology is basically there's an opening between the atria. Blood is shunted from left to right. These patients are going to be acyanotic, usually associated with a possible right ventricular problem. Increased pulmonary artery blood flow and size. So it's going to have an increase in blood volume on the right side. And this slide just goes into more detail. You have the mixing of the blood because of the septal defect. Now, atrial septal defect. Manifestations are mostly going to be asymptomatic. You will oftentimes hear a murmur. Diagnostics with this, they're going to do an echocardiogram and a chest x-ray. Now treatment is going to be, they're going to do a pre-op intervention, indicated only if the atrial septal defect is large and has CHF, usually asymptomatic, and they may close spontaneously by 2 years old. Okay? Now, diuretics are usually used to control the signs and symptoms of CHF. They will do surgery on preschool age if needed. TOC will be done for certain ASDs and a non-surgical device placement, and also surgical repair, so suturing or patch to repair that defect. Complications with the repair, they can go into atrial dysrhythmia or heart block, and it's related to edema at surgical site that interrupts the conduction system. This is usually a temporary complication. Now, with repair, the outcomes usually they'll have a normal life, no problems. Without repair, usually we'll end up with pulmonary hypertension. Now we're going to talk about a ventricular septal defect. Incidence is about 50% of congenital heart defects are going to be ventricular in nature. It's going to be an opening between the vents, so left ventricular and your right ventricular, so left to right shunt. Acyanotic, left heart enlargement, and decreased pressure on the pulmonary artery and pulmonary venous congestion. This shows normal heart, and it shows a heart with ventricular septal defects. It talks about the different things that's going on here. Now, manifestations, they're going to be, if it's just a small, they're going to be asymptomatic. If it's moderate to large ventricular septal defect, you're going to see CHF. They're going to be tachypnic, diaphoretic, and fatigue easily. These patients are going to tire before finishing feeding. They're usually not cyanotic. You will hear a murmur. It'll be loud and holocystic. Now, diagnostics are going to be done with an echo and a chest x-ray. Treatment, if it's small and they're asymptomatic, 75 to 80% will close spontaneously. Usually they're closed by an interventional cardiac cath, or they may be left alone and close on their own. Now, large, you're going to treat medically for the first few months. They're going to monitor for weight gain and for any kind of signs and symptoms of respiratory complications. Now, digoxin and diuretics will be used for signs and symptoms of CHF. They're going to increase the calorie formula. Some will be put on tube feedings for infants with tachypnea or who tire with feedings, and surgery if the signs and symptoms persist. Now, post-op complications, they can occur with these, and it could be atrial ventricular dysrhythmias or complete heart block. They could end up with a residual shunt or leaking at the repair site. So outcomes for these individuals will be, if it's a small, they'll usually have normal health. Large, if it's repaired in the first 2 years, they usually have normal health. And without surgery, they'll end up with heart failure and endocarditis. We're going to talk about patent ductus arterius, or PDA. Incidence is about 5 to 10% of all children. Preemie with weight less than 1,700 grams is 45%. If they're less than 1,000 grams, it'll be 80%. In girls, usually, and it's 2 to 1, and it's increased incidence with high altitudes. Now, pathophysiology, usually it's this connection between the pulmonary artery and the aorta should start to close within the first breath. It may take up to 3 months to close. Now, what this does is a left to right shunt of the blood, and the blood shunts from the aorta high pressure to the PA, or pulmonary artery, with less pressure, and back through the lungs to the left atria, to the left ventricle, and then back to the aorta. So right ventricular hypertrophy occurs, and you'll have increased pulmonary circulation and acyanotic. Now, manifestations, they're going to be, if it's a small, they're going to be generally asymptomatic. If it's large, they're going to have signs and symptoms of CHF. You're also going to hear a murmur, so it's going to be continuous under the left clavicle in older children, a short systolic sound in newborns. They will have a water hammer pulse and a widened pulse pressure. Diagnostics is going to be done with chest x-ray, and it's usually going to look normal. The echo is going to be the one that shows the defect. Now, a water hammer pulse is basically a forceful bounding pulse, then collapses suddenly. You'll see capillary pulsations in the fingernails, and this equals basically cardiac insufficiency. So that is what a water hammer pulse is. And this is another slide that just shows left to right shunts. Treatment for this PDA is basically to administer prostaglandin inhibitors. Note, prostaglandins keep the PDA open. In a preemie, they're going to use indomethacin, which is an NSAID IV that they can repeat up to 3 times every 12 to 24 hours. In a full-term infant, it's not effective. If they are symptomatic with CHF, then closure is indicated. So surgery, symptomatic full-term infant, they're going to do surgical ligation. In an older asymptomatic child, they can do elective closure before the age of 5 years old. There's different types of surgery, though they could do an interventional cath with Draken coated stainless steel coils. And if it's a large defect, they'll do surgical ligation. Complications that can occur, they can have injury to the laryngeal nerve causing hoarseness. They could also have injury to the left phoretic nerve causing paralysis of the left hemidiaphragm, and both are rare complications. Now, outcomes with correction, these patients will have normal health. Without treatment, heart failure, pulmonary vascular disease, and endocarditis can occur. Patients with decreased pulmonary blood flow, shunting of the blood from right to left, they're going to lead to hypoxia, cyanosis, polycythemia, and erythrocytosis. Talked about that before. The different types we're going to talk about is pulmonary stenosis and tetralogy of Fallot. Things we're not going to talk about that are in your book if you want to read is transposition of the great vessels and tricuspid artesia. pulmonary stenosis, there's valve stenosis, subvalve stenosis, and supravalve stenosis. Pulmonary stenosis usually occurs in 8 to 10% of all congenital heart defects. Pathophysiology is basically the narrowing of the pulmonary valve with obstruction of blood from the left to right ventricle to the lungs, from the right ventricle, to the lungs. Now the right ventricle can't pump enough blood into the pulmonary artery, and this leads to right ventricular hypertrophy and eventually to right ventricular failure. Now, the degree of pulmonary stenosis is determined by the right ventricular systolic pressure at rest. So if it's mild, they'll have low pressure. If it's moderate, the right ventricular is going to be equal to the left ventricular pressure. And if it's severe, then the right ventricular pressure will be greater than the left ventricular pressure. Now, manifestations you're going to see, mild and moderate, are going to be asymptomatic. If they're severe, you'll see dyspnea upon exertion, fatigue, and cyanosis, and they will have a murmur. Now, diagnosis, a chest x-ray will show severe pulmonary stenosis, and they may have cardiomegaly. Echo is going to show the size, function, and anatomy of the pulmonary valve. Manifestations that you're going to see, we already talked about all those. Treatment is prostaglandins to keep the PDA open for blood flow to flow to the lungs. And different procedures they could do is a valvoplasty or valvotomy. Now, complications that can occur, they could have ventricular arrhythmias during the operation. Also, they could develop a pulmonary valve insufficiency. So outcomes for these patients, they may always have a murmur. If they have mild stenosis, it can worsen. They're going to have follow-up done with echoes pretty much the rest of their lives. Now, tetralogy of Fallot. The incidence is about 10% of all congenital heart defects. 15% also have chromosome defects. And most common is a cyanotic defect. So pathophysiology, they're going to have pulmonary stenosis, ventricular septal deviation defect, overriding aorta, right ventricular hypertrophy, and pumping against the PS, or pulmonary stenosis. So pulmonary stenosis increases pressure at the right side. The blood shunts from the right to left ventricle and overriding the aorta. Now, overriding aorta, congenitally malpositioned aorta, is a congenitally malpositioned aorta, the origin of which straddles the ventricular septum, so it receives ejected blood from the right ventricle as well as from the left. It is found especially in the tetralogy of Fallot. So tetralogy, tetra means four. Four failed problems. So you have pulmonary stenosis, a large ventricular septal defect, an overriding aorta, and right ventricular hypertrophy. So pulmonary stenosis increases pressure at the right side, blood shunts right to left ventricle, and the overriding aorta. Now the incidence is 10% of, like we said, of congenital heart defects. 15% also have a chromosome defect, and most common is a cyanotic defect. Now, manifestations, you're going to see cyanosis. It depends on the degree of pulmonary stenosis. You may not see it in a newborn, but they will have a bluish tint if you do see it. So their whole body will have a bluish tint. Polycythemia, or increased red blood cells, trying to increase the O2 to the cells in the body. You're going to have increased viscosity of the blood, so it's going to be too thick. You're going to have problems with clotting, thrombosis, embolism, and possible CVA. Now, some things you're going to see manifestation. They're going to have problems breathing if they squat or assume a knee chest position. Syncope or fainting, so they're going to have decreased O2 to the brain, usually with crying or exertion. And they're going to have hypoxic episodes or TET spells, usually with crying or exertion. And this is just a baby that has tetralogy of Fallot, or however you want to say it. Diagnostics, labs, they're going to pick up on the increased hematocrit, hemoglobin, and red blood cell, and decreased O2 sat. That will tell them that they have polycythemia. Chest x-ray is going to look normal or classic boot-shaped heart. An echo will show right-sided hypertrophy, decreased size of the pulmonary artery, and decreased blood flow through the lungs. Cardiac cath is going to show a defect, and a murmur, of course, you're going to hear all over the left side, anterior and posterior. So, squatting to breathe, cyanosis, and clubbing, all those things are examples of things that these patients will show. Treatment with TET spells, they're going to do the knee chest position. They're going to give them O2 and give them morphine for the pain. Without TET or hypoxic spells, they're going to do Inderal, which is a beta blocker, PO, to dilate the vessels. They're also going to do volume resuscitation. Now, surgery with this, approximately 3 to 12 months of age, it's done, but it varies. If they do the Blaylock tossing procedure, it's going to be a temporary palliative procedure. It's going to create a shunt using the subclavian artery between the pulmonary artery and the aorta, and this will allow the blood flow of the PDA to the aorta, to the pulmonary artery, to the lungs for O2, to the left side of the heart, to the aorta, to the body. Now, no palpable pulse in the right arm related to the use of the subclavian artery for the shunt. So once they have that, they will have no palpable pulse. They'll also have no blood pressure or venipuncture done in that right arm. Now, if they do the Brock procedure, this relieves the pulmonary stenosis, ventricular septal defect, and overriding aorta. Complications from these, they could have dysrhythmias related to the edema of the septum and conduction interference. They could also have low cardiac output, and long term, the residual ventricular septal defect, leaking, and pulmonary regurgitation across the patch. Now, outcomes, surgical mortality is usually 2 to 5%. Without surgery, 11% live past the age of 20, and the percentage decreases with each year after that. 3% will die without surgery by the age of 40. 3% by the age of 40, and then severe dyspnea, they'll have severe dyspnea, growth restriction and clubbing of fingers, Ventricular arrhythmias, cardiac failure, and sudden death usually occurs with these. Now, the different types would be coarctation of the aorta and aortic stenosis. There's also hypoplastic left heart syndrome. We're not going to talk about that, but you can read about it in your book. Now, coarctation of the aorta, the incidence is about 8 to 10% of congenital heart defects. Boys are affected more than girls, and it's basically the narrowing of the lumen of the aorta due to a constricting band. This will increase the pressure proximal to the constriction and decrease the pressure past the constriction. Now, increased resistance of the blood flow out the left ventricle leads to left ventricular hypertrophy or increased work on the muscle. Now, manifestations you're going to see, if it's mild, they'll only have signs and symptoms of absent femoral pulses. If it's severe, they'll have CHF once the PDA closes. Now, the left ventricle cannot eject all its blood and it backs up into the lungs, and blood cannot go to the system, so it results in higher blood pressure in the heart and upper body as pressure in the subclavian artery increases. You also see hypertension, so classic signs and symptoms is upper extremity hypertension. Usually you'll find on a well check in an asymptomatic child. The increased upper body blood pressure will have an effect. Those patients will have headache, vertigo, and fainting. Children under the age of 3 cannot verbalize signs and symptoms, so irritability is the main clue with those. So children under 3, it's irritability. Also with the increased blood pressure, nosebleeds and CVA can occur, especially if it's dangerously high. With the coarctation of the aorta, they also will have pulse defects. So they'll have absent brachial pulses if the coarctation is proximal to the left subclavian artery. They also have absent femoral pulses. So check all visits, newborn and well baby. You need to check their femoral pulses. Leg pain will also occur. So older children will have leg pain. And this is all related to the decreased blood supply an O2 supply, and this is often confused with growing pains. They'll also develop rib nodules, which is collateral circulation develops around the coarctation and will cause this. Diagnostics: blood pressure in the arms, 20 millimeters per mms per Hg, higher than in the legs, and that's the opposite of normal, so usually it's higher in the legs. Your EKG, echo, and MRI and X-ray of older children will show the left heart enlargement and notching of the ribs. So that's back pressure and collateral circulation. Now they possibly will have a murmur. It'll be soft to moderately loud, systolic at the base of the heart, radiating to the left interscapular area. Now severity is based on the arm-leg pressure gradient. Treatment is usually done with surgery between the years of 3 to 5 years of age. The timing of the surgery depends on the infant's hemodynamic stability. They can do a balloon catheter dilation. This is used also for coarctation. Now the cath is passed through the femoral up to the coarctation, and the balloon is inflated to relieve the stricture. Now the surgery, like we said, if possible, to wait that long. If done earlier, more likely to have recoarticulation. If recoarticulation occurs past 6 years of age, it becomes very serious. Some other surgery they can do is just dissection with and without grafting and anastomosis. What the surgery does is remove the stricture and anastomosize the ends. If it's large, it may have to graft a piece of the subclavian artery to the anastomosis. Post-op treatment, they'll use digitalis and diuretics to prevent and decrease CHR. They'll also use antihypertensive meds. They may still have upper body elevated blood pressure, and this also helps to prevent post-op bleeding. And this is a thoracotomy incision with a chest tube after repair of coarticulation. Now, chest tube output should be 2 to 3 mLs an hour, cc's an hour per kilogram per hour for the first few hours. Then it should taper off. So drainage can be bloody but should not look like fresh blood. So FYI, some neonates will not weigh in kilograms, and so that'll have to be figured differently. The complications you can see from coarticulation of the aorta: CHF, continuing hypertension, bleeding. Long term, it could have recoarticulation and repaired, especially if it's repaired in infancy or after the age of 6. Aortic stenosis, 3 to 6% of congenital heart defects. This occurs in males more than females 4 to 1. Stenosis or stricture of the aortic valve, and this obstructs the left ventricular outflow, decreases the left ventricular ejection, and prevents blood flow from left ventricular from it. Also, left ventricular hypertrophy from increased pressure in the heart. So the left ventricle fails, increases the pressure in the left atrium, and increases the pressure in the pulmonary veins to the pulmonary and causes pulmonary edema. Manifestations, if they're asymptomatic, they're usually diagnosed upon regular exam. If it's serious, it will be diagnosed in a newborn. It could be critical, and they could die without treatment. With these patients, they'll hear a murmur. It's a rough systolic sound. Second right intercostal space is where you hear it. It may radiate to the shoulder, right shoulder and clavicle, and up the neck, and may also hear at the apex. A thrill can be felt at the substernal notch on these patients. Now, severe stenosis, you're going to have decreased cardiac output. They're going to have faint pulses. They're going to have decreased blood pressure, increased heart rate, and syncope. Now, infants cannot feed for long periods of time. An active older child will have chest pain similar to angina, exertional fatigue, and also dyspnea. Now, sudden death related to decreased O2 occurs because it occurs related to decreased O2 needed with exertion. So these patients have to be careful. Diagnostics, you're going to have an echo done. Dicrotic pulse, which is 2 radial to 1 apical beat to use the diagnosis, and also a chest x-ray should look normal or could have cardiomegaly. Now, treatment for aortic stenosis, they're going to use prostaglandin to keep the PDA open. An infant with critical aortic stenosis especially. Beta blockers, they may be needed to decrease the cardiac hypertrophy before correction. They can also do balloon valvoplasty. Now, surgery is going to divide or dilate the stenotic valve, and they may need replacement. An artificial valve replacement can be done, and they will need prophylactic antibiotics to prevent endocarditis. Now, complications that can be caused: aortic regurgitation, the valvoplasty, arrhythmias, heart block, and bleeding. All those can occur during a valvoplasty. Now, outcomes, if it's unrepaired, it depends on the severity of the stenosis. Now, nursing care of a child with any kind of cardiovascular disease, especially congenital defects, you want to maintain their respiratory status and relieve hypoxia. So you're going to administer O2 as ordered. With infants, you need to put them in a knee-chest position with their head and chest up. Older kids can squat, and you need to make sure you manage TET spells. You also want to ensure adequate nutrition. So you want to monitor their potassium related to the use of diuretics. In infants, you're going to feed slowly in an upright position. You're going to use a soft nipple with an enlarged hole, and you're going to feed at the first sign of hunger to avoid crying. Now, these infants are going to need small, frequent meals. They're going to burp after each ounce, and they need to have a high-calorie formula with iron, and may need tube feedings also. Older kids, you're going to give choices to, but healthy choices. You also want to ensure adequate hydration, especially with cyanotic defect kids. And you may maintain a low sodium diet with fluid restriction. You also want to prevent infection, so you're going to avoid contact with any infected people. They need to keep immunizations up to date. You're also going to monitor for signs and symptoms: unexplained fever, oral petechiae, malaise, weight loss, nausea and vomiting, changes of the murmur, or development of a new murmur. Also, these patients are going to have prophylactic antibiotic therapy prior to dental work, and if infection is suspected, cultures are to be done immediately. These patients, you want to check their vital signs frequently. This is going to prevent hypothermia. Also, you're going to give them Tylenol for any fever. You want to keep the children calm and decrease any anxiety level, because this is going to make it harder for them to breathe, and it's also going to exacerbate the situation. So a lot of these children are going to have morphine ordered for them. You want to respond quickly to any crying. You're going to organize nursing care to help maximize the rest periods, and you want to use passive stimulation on these patients. You don't want to get them wound up. Drug therapy, they're going to do IV replacement of fluids, Inderal to increase blood flow, neosynephrine to increase blood pressure and decrease shunting by the increasing SVR. They're going to use Tylenol for fever. Now, fever can trigger a TET spell, so we need to try to keep that under control. At the slightest look of fever, we need to be given Tylenol. Indomethacin or prostaglandins to control PDA. So indomethacin to close and prostaglandin to keep open. Just remember that. And then digitalis, especially for those with CHF. Now, part of your care is you're going to help the family accept the diagnosis. So oftentimes they'll have guilty feelings that they've done something to cause this. You also want to teach the family and the child about the illness and management of the illness. This is important, especially what they can and can't do and how much they can do. So all that is very important. Their diet, all that thing you have to teach them about. Okay, that's it for this section. The next section we'll go to is cardiac surgeries, and I'll see you there in just a little bit.